discussed the narrow caris complex, the regular, and we discussed sinus tachycardia, atrial tachycardia, SVT, supraventricular tachycardia, narrow complex, irregular tachycardia, atrial fibrillation, atrial flutter with variable conduction, multifocal atrial tachycardia, and wide caris complex, mainly ventricular tachycardia. So today we'll discuss bradyarrhythmias. So first, general approach to patient with bradycardia, what to do with patient with low heart rate. Then we will go to specific diseases of the sinus node and atrioventricular node. So basically, if a patient with bradycardia in emergency room, first, usually how they do present, usually present with just mild palpitations, dizziness. However, it could be more serious symptoms like syncope, loss of consciousness, or severe chest pain. They may have heart failure symptoms or signs in physical exam later. And it's important always to check about the previous cardiac history and any medication use. One of the common causes of bradycardia is medications. So basically this is in the history. In physical exam, what is the most important thing in physical exam? Patient heart rate 40 in emergency room. General appearance. Why? If the patient is conscious oriented, it's totally different from patient who is lethargic, unable to talk. It's more emergency. Vitals, blood pressure. If normal blood pressure is totally different from hypertensive patient. And you may look for any evidence of heart failure, any added heart sound, or structural heart disease. But the most important is look at the patient hemodynamically stable or unstable from history and from physical examination. What investigation you need to do? A patient with bradycardia, ECG, number one, excellent. Electrolytes, because significant electrolyte issues can cause bradycardia, hyperkalemia, hypokalemia, hyper or hypocalcemia.
CBC?
I'm talking about investigations. CBC, there's severe infection, of course, what is the cause of bradycardia, so sepsis, right? Thyroid function test, very important. Hypothyroidism, one of the common causes of bradycardia, and always we have to rule out hypothyroidism. So that is the 12-lead ECG, the blood test. Chest X-ray, just if the patient in heart failure, you may check the chest X-ray. Holter, do you know what is Holter?
This is the one that keep on the body for.
Yeah. So actually it's the machine, the person who discovered this, his name is Holter, Mr. Holter, so it's named after him. And it is a small machine. It is a small machine, has electrodes in the body. We call it for 24 hours continuously. That's what we do for 24 hours Holter. Now we can record for 48 hours, 72 hours. Continuous recording. And it is helpful if the patient has symptoms and ECG did not show significant abnormalities and the symptoms is frequent. So because we are monitoring for a short period of time. If the symptoms is not frequent, like once a week or the other week, if you do Holter, it may not show the problem. So we may go for what we call event monitors, small devices like this. Some of it with patches that says for 2 to 3 weeks. Others without patches. They carry it with them. If they have problems, they just put it in the chest, record, and send. It can be trans-telephonic, we call it. It can be different ways. With the smartphone now we have small devices attached to the phone, iPhone, and iPhone itself now and the watches has different ways of monitoring the rhythm. So it's much easier nowadays compared to the past. Okay, how to manage? So now we see the patient. We have the history, we did physical, we did some investigations. How to manage patients with bradycardia?
Depends on
This is general one. Depends on what's on?
what the disease, what's causing it.
Okay, the cause is okay, but actually why I started with this one, because sometimes even you may not have time to look for the cause. If the patient is hemodynamically unstable, we have to manage immediately. The same for tachycardia, by the way. Tachycardia hemodynamically unstable, we look for the APCs, we go for cardioversion or defibrillation. Bradycardia is a little bit different, but again, if the patient hemodynamically unstable, hypotensive, lethargic, not responding well, we have to think about the APCs. So maintain the airway, the breathing, give oxygen, keep MPO in preparation for procedure, obtain IV access as early as possible. If the first line therapy here is atropine. Atropine, look, the parasympathetic increases the heart rate. It is transient. You can just repeat it 2 or 3 times till you are preparing for the next step of management. And the next step, you may give isopreterenol, sympathomimetic agent that increases the heart rate. This is continuous infusion. Or you may think of giving temporary pacing. So for emergency situation, after the ABCs, atropine number 1. Number 2, isopreterenol or dopamine, and continuous infusion that increases the heart rate and blood pressure. Think about temporary pacing. There are 2 ways of temporary pacing. One is called transcutaneous. So patches on the chest can be placed anterior and lateral. This is one way, or anterior and posterior. Both are okay. It's connected to a machine, the same as the defibrillator, by the way. And most of the time in the hospital now, the defibrillator machine has pacing. So you just turn from defibrillator, shift it or switch it to pacemaker. So this patch is connected to the machine. We start to stimulate the heart electrically by increasing what we call output, and we will increase the heart rate till we are seeing that the heart rate is responding to us. So this is stimulation of the heart externally. As you can imagine, it's painful because we are delivering electricity through the chest wall. So this is only for emergency situations. Or patients losing consciousness transiently, like non-pulse, no activity for a few seconds, we start using the TCP, they call it transcutaneous pacemaker, and then we stop. Patient in ICU with severe sepsis, we cannot put anything internally, so, and they are sedated, they don't feel pain, so still we can use the TCP transiently. The more commonly used one is called transvenous. So we have wire like this, it's called the lead, and we give it through the vein, with a femoral vein, internal jugular vein, or subclavian vein. You know, all the veins will go to the right side of the heart. And we place it in the right ventricle, connected to a machine like this. This is just an example of it. And we start to increase the output because the electricity till we see we are stimulating the heart. And once we start to stimulate the heart, we increase the heart rate 60, 70, 80 to the level we want. So for emergency, atropine number 1, continuous infusion of sympathomimetics like isopreterenol or dopamine, transcutaneous pacing or transvenous temporary pacing. If the cause is reversible, everything is back to normal, okay, you're fine. If there's no reversible cause, we go for permanent pacemakers because the final solution for bradycardia is pacemaker if it is not reversible. Now, if the patient is hemodynamically stable, so he is in emergency room, rate is 40 beats per minute, blood pressure is fine. This is the time actually you can look for the underlying cause, exactly what's the underlying cause. However, it's important to put in mind, patient can change from hemodynamically stable to unstable anytime, so keep monitoring the patient. Keep him in intensive care unit or CCU, coronary care unit, for observation. We don't discharge him usually, except if this like chronic bradycardia, everything with it is normal, then we say, okay, we can work him out as an outpatient. Now, let's think about what causes bradycardia. So, why this patient is having 10 to 40? Of course, there are physiological and pathological causes. Just try to figure out or think about causes of bradycardia. What can cause bradycardia?
Increased vagal tone.
Excellent. So, what is one of the common vasovagal syncope, for example? Typically, high vagal tone. They have bradycardia, they may have hypotension, and then transiently, and then back to normal. So, high vagal tone. Athletic people, they have bradycardia, which is physiologic.
If not the SA node, it's like another.
Yeah, so what pathologic diseases can cause this? One of the causes.
Hypothyroidism.
One of these hypothyroidism reversible causes, yeah. Any other causes? Remember, medications, when I say in the history, very important to check medications. One of the common causes for bradycardia is medications. So medications like calcium channel blocker, beta blocker, and others. So you can think about functional. What it means that the conduction system is normal, but this is extrinsic factors. Sometimes we call it extrinsic factors, high vagal tone, medications, electrolyte disturbances. Or it could be pathological diseases. Any pathologic disease in your mind from pathology, remember it can affect the sinus node or the AV node. So congenital, like congenital complete heart block, congenital sick sinus syndrome, rarer than that. Degenerative changes in elderly, the commonest cause they need a pacemaker is because of degenerative changes, replacing the pacemaker cells in the pacemaker with fibrous tissue, so it will lose function with time. It can also be in the AV node, replaced with fibrous tissue, and then with time they get no conduction in the AV node. Others, remember the eyes, ischemic heart disease or infarction. Remember infarction, it can affect the myocardium. Part of the myocardium is included and it is the conduction system. Infections like infective endocarditis, especially aortic valve, when there is abscess and that abscess affecting the AV node, it can damage the AV node. Infiltrative diseases like amyloidosis, inflammatory conditions like vasculitis, myocarditis, calcifications in the AV node, in the aortic area, hypothyroidism as mentioned. It could be still iatrogenic. So sometimes when they replace the valve, mitral, tricuspid, or aortic, they are close to the conduction system. So it could be transiently affected because of edema, inflammation, or process, or it could be permanently damaged. So these are the typical causes for any disease in the body. It can involve the conduction system. So look at this. This is lead 2. What do you notice in lead 2? Heart rate is what? Just rate is less than 60, anything else is normal. So we're dealing with sinus bradycardia. Remember, sinus bradycardia by definition is heart rate less than 60 beats per minute. There is P wave, and it is similar to the sinus P wave. This may happen normally, for example, during sleep. Most of the people will have bradycardia normally because it increases parasympathetic, decreases sympathetic during sleep. It can happen normally in young athletes and in some elderly people. The diseases, if you just remember what I mentioned earlier, it's enough, but it can look to specific, again, could be physiologic, could be increased vagal tone, could be medications, degenerative changes, myocardial infarction, hypothyroidism, increase intracranial pressure or cholestatic jaundice, one of the common systematic diseases that may can affect the AV node function, and cervical or intestinal tumors involving the autonomic nervous system. Just if you think about the common thing is common, so the one I mentioned earlier can affect the AV node or sinus node.
Can you please repeat the sinus bradycardia and the CDA?
This one?
Yeah, I don't know.
The only thing is everything is normal except the heart rate is less than 60. So that is actually typical for it. So if the rate is less than 60 but everything else is normal, we are dealing with sinus bradycardia. Okay. So look to this one. What do you notice here? P wave Keras complex and rate is fine. Then suddenly we have no activity at all, and the same for the other one, and then back again. So this is called sinus pulse. This could be due to arrest or could be exit block. You don't need to differentiate between the two, but again, arrest means the sinus node is stop firing. So this is an impulse formation problem. The impulse is not formed in the sinus node, so it stops working, then back again. Exit block, it means sinus node is working fine, but not conducting the impulse to the atrium. So if the sinus node fires, there is activity in the sinus node, but it is not spread to the atrium, we will not see P wave, because P wave is atrial depolarization, it's not sinus node depolarization. So how to know which is which? If I map P wave to P wave in this one, I expect P wave to come here, but there is no activity. Next P wave comes on time. So what it tells me, this gap here is like double, or it could be triple the P wave to P wave before. So the sinus node is firing the same rate, but sometimes conducting to the atrium, sometimes not conducting to the atrium because of pathologic process between the atrium and the sinus node. Exit block. If you try to map them, they will not map it. So remember, when sinus node fires, we see nothing in the ECG. It's small tissue, small electricity, we cannot detect it by electrodes outside the body. When it activates the right and then left atrium, the right left atrium is not there, sorry for that. But anyway, right atrium, then left atrium, then we see a P wave. P wave is atrial depolarization. And if we look to the P wave, and it is positive in lead 2, positive in lead 1, we know it's coming most likely from the sinus node. So we see this is sinus P wave, but actually the depolarization is atrial depolarization. So if the sinus node fires, did not conduct the impulse to the atrium, we call it exit block, sinus node exit block. If the sinus node stops working, this is called arrest. You don't need to differentiate between the two processes, but you may read about the two terminologies, you understand them. But what you can say is, if you see something like this, there is a pulse and there is no P wave, so most likely this is sinus node disease. So this is more serious, of course, than just sinus bradycardia. So this is the second process, disease process that can involve the sinus node. The third one, and maybe you heard about this terminology, Tachybrady Syndrome. Did you hear about it? Tachybrady. So what happened, and actually just explaining it by Holter is better than we'll go there. If you look to this one, this is a Holter recording. Holter will have 2 channels or 3 channels. This is 2 channels, channel 1, channel 2. And if you look to this one, patient is okay, his sinus rhythm is fine. Then what happened here? He went into irregular rhythm, non-occurrence complex, nuclear P wave. What is this? Atrial fibrillation. So he was sinus, then he went into atrial fibrillation. Okay. What happens if the atrial fibrillation stops? In normal people, they should go back to sinus rhythm, right? And that within 1.5 seconds. So sinus node is functioning normally. Within 1.5 seconds from AFib, once it stops, they will go back to normal sinus rhythm. But let's see what happened to this patient. The AFib stops. He has, what do you call this?
Pause.
Long pause. It is about 3 seconds, 3.5 seconds. Is this normal? Not normal. Because normal people, as I mentioned, 1.5, so about here you expect him to come back to sinus rhythm. So he's tachy at this area because his atrial fibrillation with fast ventricular response. Then he went into long pause and then bradycardia. So that's why we call it tachybrady. And most of the time you see pauses in between. Not necessarily every time they will have a pause, but most of the time you'll see some pauses in between. What it tells you that the sinus node is not working normal. This is more serious, by the way, than this exit block that I showed you or addressed. More serious than this sinus bradycardia, that is the first disease can involve the sinus node. So 70% of sick sinus syndrome in elderly is due to Tachybrady syndrome. If there is no reversible cause, of course we have to go for a pacemaker. Again, the same patient, fast rhythm, then suddenly has long pause, and of course we'll go sinus bradycardia. This is called Tachybrady syndrome. So sinus bradycardia, usually not that serious. Exit block or arrest is more disease to the sinus node. Tachybrady is another thing. You may hear another terminology, you need to remember it for the future, but we call it chronotropic incompetence. Chronotropy is heart rate. Incompetence, it means inability to increase the heart rate. With exercise, normally the cardiac output depends on stroke volume and heart rate. Heart rate goes up, stroke volume goes up, cardiac output goes up with exercise. If somebody cannot increase his heart rate with exercise, we call it chronotropic incompetence. This is another evidence of disease of the sinus node. I did not mention it here, not to bother you with it. So if there's sinus bradycardia, most of the time just observation, actually most of the time. If the patient really symptomatic, think about atropine or isoproterenol or transient pacing. Very rarely, except if the patient has these long pauses in between and causing symptoms, then we may need temporary pacing. Long term depends on the underlying disease. If there is reversible cause, just correct that reversible cause. Stop the medication that's causing it, correct the hypothyroidism. If sepsis, treat the sepsis. If there is no reversible cause and they have long pauses, they may need permanent pacing. Any question about sinus node disease? Okay. Now, the second part of the conduction system is the AV node, atrioventricular node. We know that atrioventricular node conducts impulse from the atrium to the ventricle, then bundle of left and right and left bundle branches. So we will discuss diseases that can affect the AV node and also the morphology in left and right bundle branch block. It does not cause bradycardia, but it is important to recognize it in ECG. Causes lots of them, but if you remember the process I told you earlier that can involve any part of the body, the reversible one, high vagal tone, medications, electrolyte issues, again hypothermia, hypoxia, hypothyroidism, pathological disease. Any pathological disease in the heart, cardiomyopathy, myocarditis can cause it. Think about also collagen vascular disease, neuromuscular diseases can cause also, and infiltrative diseases of the heart can cause AV node disease. You don't need to remember all of them, but just think about the usual process. Infections, inflammation, infiltration, it can affect the AV node, it can affect the sinus node. Now, I think we discussed this in the first lecture this week, but just go again to see this. This is 3 leads now. We have V1, and we have V5, I think, and we have lead 2, yeah, V1, V5, and lead 2. This is continuous recording, this is straight. What is the main problem here? And it is conducting all the time, just slow. Everything else is normal in this ECG. So what is this called? First degree AV. It's just delay conduction of impulse from the atria to the ventricles. Most of the time it's benign disease. We don't do anything about it and it's not a contraindication. Very, very rarely, if this is very long, like more than 400 milliseconds, they may have heart failure symptoms because there is no coordination between atrial and ventricular activity. But this is rare. Most of the time we just observe it, there is no need to do anything. This is called first degree AV block. And this one, you see P wave intermittently not conducting. It's conducting here, but suddenly there is P wave with no QRS complex. It means there is problem in the AV node. And once we see conduction most of the time and no conduction intermittently, we are dealing with second degree immediately. In second degree, there are two types, type 1 and type 2. Is this type 1 or type 2? One.
Because PR is increasing.
PR is increasing, and then we have no conduction. This is called Mobitz 1 or second degree type 1. Again, most of the time it is happening at the level of the AV node. Nothing need to do about it, no need for intervention. This one? Again, Mobitz 2, why? We see a P wave with no QRS complex, and before and after there is conduction, so it is second degree. And we look to the PR interval, they are fixed before and after. So we are dealing with second degree type 2 or Mobitz 2. The block here is below the AV node, below the head, so it is more serious, can progress to third degree AV block.
Doctor, in this ECG, the PR interval is normal, right?
Yeah.
So how can we differentiate between this ECG or between the premature atrial?
You measure the P wave to the P wave, and the P wave to P wave is the same. So that's not. Sometimes we call blocked PACs can mimic this one. In that case, you see a PCA. The P wave will be very short because if I take this P wave to this P wave, this is on time, right? And this is on time. If this P wave is very premature, we call it blocked PAC. It's not a second degree AV block. Is this answer your question, or still you have a?
But I mean, how can we differentiate between the ECG?
Between what and what?
Between the premature one and this one, the block.
But what is the premature? By the way, there is no block usually. Premature beats, remember, it's just beat comes before the expected time. Could be premature from atrial, could be premature from junction, could be premature from ventricular. We see a P wave in the atrial, and we don't see it in junctional or ventricular, and there's QRS complex here. This is a P wave with no conduction, so it's a totally different process. There's P wave, there's no QRS complex. So it means that the AV node is not conducting. Right? So this is Mobitz 2, we call it, or second degree type 2. This is of course more serious. Again, I think I showed you this before. So if you look to this one, the main thing here is, what is the main problem in this ECG? What strikes your eyes first? No, it's bradycardia. The patient's bradycardia. Rate is about 37. So number one, bradycardia. Is it regular, the RR?
Yes.
They are regular. Is there a P wave there?
Yes.
Always, best lead for P waves is lead 2. Is there a P wave in lead 2?
No.
What is this? What is this? Maybe just I can show it this one. I won't obstruct your vision. So if you look to this one, by the way, you can notice it here. What is this? P wave. So there are P waves. But are these P waves related to the QRS complex? No. There's no relation between the two. So we're dealing with third degree. Third degree dissociation. They are controlled by sinus node, ventricle by. Which is the source of this QRS complex? What is junction? So it's coming from junctional area, AV node or bundle of junctional area. So the sinus node is controlling the atrium. There is no conduction, so we have junctional rhythm. Of course, this will be lower than atrial rhythm. So atrial rhythm is faster, ventricular rhythm is lower. So this is third degree AV block. Of course, serious, no reversible cause. What is how to solve this issue? Pacemaker. There's no other solution except putting a pacemaker. So P waves, and R to R, they are regular atrial rate, which is P wave to P wave. is faster than ventricular rate, which is R to R. So we're dealing with third degree AV block. Now, bundle branch block. Bundle branch blocks in ECG is important to recognize it because some changes that you have to differentiate from ischemic heart disease and from other problems. So, is this left bundle or right bundle? This was this about first.
This is left bundle branch
Why?
because the V1 and V2 are the R wave are negative.
Right.
Yeah, so
And
that tells us
and V56 is positive.
Yeah.
And this is
this is right bundle branch block. Because the
XR,
other-
SR. Okay. So let me just tell you because sometimes we'll try to explain it a little bit, but sometimes just for your information, sometimes just to remember it. This is the right bundle, this is the left bundle. We look to the V1 initially, just to concentrate on V1. Where is the location of the V1? For the intercostal space? To the right. So this is an anterior lead, and this is the electrode in V1. When there is right bundle branch block, what happens is that left ventricle activated initially, then we have to activate right side. So the main force of right bundle, is it going to anterior or to the lateral? Because V1 is anterior, V6 is lateral. Is it going anterior or going lateral? The main activation? Anterior. So what do you expect V1? V1 positive or negative? Positive. So if you see V1 positive, and actually it is typical, we call it RSR prime, will have it, but V1 will be positive. A left bundle branch block. The right side activated initially, then the activity spreads to activate the left side. So is it going anterior or lateral activation? The main force of activation? Lateral. What do you expect V1 will be positive or negative? It is moving away from V1. So that is why V1 is positive in right bundle branch block and negative. And to remember it, right bundle, you have R wave in V1. Left bundle, you have S wave in V1. This is again patient left bundle. The main characteristic is two things. Number one, QRS complex would be wide. Why? Because conduction here is slower. So it has to activate the right side, but the activation of the left is coming myocardial cell to myocardial cell to myocardial cell. Very slow activation. So it has to be the duration of the QRS complex more than 120. So it is wide, number one. Number two, activation at the end is away from V1, so we will have deep S wave in V1. It is towards V6, so we will have positive R wave in V6. So if you see that morphology, wide QRS complex, number one, small r deep S in V1, RSR in V6, we are dealing with left bundle branch block.
So in the bundle branch block, we look at V1, V6.
V1 and V6. This is the typical example. V1 and V6. So this is another explanation for it. So in the left bundle, septal activation. Septal activation initially is going from right to left, opposite to the normal because the left bundle is blocked. So we start to have positive in V6, but it's negative in V1. Again, the main activation is going away because right side is activated initially, then left side. So we will have deep S wave in V1 and bigger R wave in V6. So this is typical left bundle branch. And right bundle, remember RSR, small r, deep S, large R prime. In V6 and 5 we have deep S wave. RSR in V1 and positive R with deep S, so the S here is bigger in V6. This is just another cartoon explanation for the right bundle. We'll quickly over it. So initially, impulse comes from the sinus node, activate the atria, we have a P wave, right? The P wave is there. And just now I'm concentrating in V1. Just look to the V1. So septal activation is going left to right. This is the normal activation of the septum, left to right, right? So V1 will be positive or negative? Positive. So it's going towards V1. So always remember, towards is positive, away from the electrode, from the positive electrode is negative. When the right side is activated, then it has to activate the left side. So going this way. So initially, sorry, because septum is activated, we finished from that one. So because we're dealing with right bundle, I was thinking of the other. So the right bundle is blocked. So the left side will be activated, right? Activation of the left side, is it towards or away from V1? It's going away from it, so we will have negative. It goes down. Then it has to activate the right side. This direction is going from myocardial cell to myocardial cell to myocardial cell. And most of the activation of the right side is this direction, which is towards V1 again. So initially towards V1, small RV. Away, deep S wave. Back again to activate the rest of the RV, large RV. And the R prime here, which is the second R, is always bigger than the first R. Because most of the activation of the right side is coming from the left side. So R is R into. V6, initial activation when it goes to the left is towards, so it is positive. When it goes away, what will happen? We will have deep S wave, because moving away from it. Yeah.
So the deeper the first S wave, the more severe the right bundle.
No, it doesn't work. There is little variation in morphology, but it's all accepted. That's why sometimes you see very huge, like R here is then this, then R prime. Sometimes this R is very, very small. Doesn't indicate anything. It's just morphological changes. Vesicular block. We know that the left bundle has anterior and posterior vesicles, right? The left bundle has anterior and posterior vesicles. The right is only one vesicle. So if there is anterior vesicular block, so this is anterior and this is the posterior. If this vesicle is blocked, impulse comes here. Which area will be activated is the posterior and inferior area initially, right? And this would, what will happen, let's just think about lead one initially. This one is away from lead one because it's posterior and inferior, right? So will produce negative deflection in lead one. The main activation then to the left ventricle is going to be lateral and superior and lateral. That large arrow. So most of the activation will be towards lead one, so we'll have large arrow. The opposite will happen in lead 3. So initial activation is towards lead 3, so we'll have small arrow. The ultimate is away from it to activate the superior and lateral part of the ventricle, we will have deep S wave. So if you look to this one, lead 1 and lead 3, is it left bundle or right, left axis or right axis or normal axis? 1 is positive, 3 is negative. And in this case, most of the time, left, and most of the time in this case, is also lead 2 will be negative, so we're dealing with left axis. So sometimes, if you're not sure, if the patient has right bundle and you see left axis deviation, we say most likely there's left anterior vesicular block. The opposite will be, yeah, this is left, and this is just a mistake I could not correct it. It's actually left posterior, should be just left posterior. So left posterior vesicular block is the opposite. It will look like right axis deviation. Okay, so just correct this one because I think I cannot edit it here, unfortunately. I tried to edit, but I couldn't. So this is left posterior vesicular block. So left anterior is like left axis, left posterior is like right axis deviation. Common causes of bundle branch block. The all process I told you before, it can involve the conduction system, including the bundle branches. Most of the time, management just observation, if just left bundle, right bundle. But I think important, so you go back to it. If you see with them, when there's big R wave, there is ST segment depression, T wave inversion. So this is not ischemia, this is part of the bundle branch block in this lead. The same for left bundle branch block. Yeah, with the same for left bundle branch block, you see ST wave changes. This is part of the bundle branch block. This is not ischemia or infarction. What is the only exception? If new onset chest pain, new left bundle branch block, think about also acute myocardial infarction. This is the only exception. Okay. Any question? Thank you very much. If you have any question, you can